This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, let me share with you a case of a secondary IOL implantation in an eye which underwent an eventful surgery about 10 days back. This case was operated 10 days back by a young surgeon, and he encountered a PC tear during phacoemulsification. So he abandoned phaco, converted to SICS, and planned for a secondary implant later. Now, clinical examination shows a peaked pupil suggesting the presence of a vitreous band here. And this is the picture, and this is the slit lamp picture after dilatation. We can see these two rings. It appears that this is a posterior capsular tear. The exact margin of the anterocapsular rim is not visible clearly. Now, before the patient is taken to the OR, let me write down how am I preparing for this case. So the first protocol always is to do the antivitrectomy. That's mandatory. The choice of IOL is likely to be either of the two. The first priority is always going to be placing the lens in the sulcus, because the posterior capsular tear is not a very large end-to-end tear. I can see some end, and I am hopefully seeing some end of the rhexis margin also. My first priority is to try to fix the lens in the sulcus, probably a PMMA lens. Well, if there is not adequate capsular support, I don't see the rhexis good enough, and then I would resort to the iris claw lens, which is posteriorly fixated. So this is the picture in the OR. Patient has received a perivalvular block, and these are the eye looks. Now, under retroillumination, I can delineate the rhexis margin, which is the outer ring here, and the well-defined inner margin is that of the posterior capsular tear. It's eccentric. Some part of it is within the pupillary area, and majority of it is outside the pupillary area. But looking at this picture, I'm quite hopeful that a posterior chamber lens in the sulcus is a possibility. So my strategy is to do anterior vitrectomy and try to prevent any enlargement of the posterior capsular tear and damage to the rhexis margin. Then the posterior chamber lens placement in the sulcus is a distinct possibility. The surgery is almost 10 days old now, and you can see that the margins of the posterior capsular tear are thickened. And that's a good sign that during intraocular maneuvering or during anterior vitrectomy, it's unlikely that the posterior capsular tear is going to enlarge, and this would be beneficial. Now, this is the scleral tunnel incision which the surgeon has made in the superior quadrant. This is a clear corneal phaco incision. I don't want to use a clear corneal incision, so I would want to create fresh ports here. So I'm just retracting the conjunctival flap, and as I'm doing it, the antechamber just flattens and it's very soft. When the eye is soft, we can't make any ports. But before filling in the OBD, I just want to put in some diluted triamcinolone acetate to check the presence of vitreous in what area it is more. So there's a reason I first push in triamcinolone acetate, then irrigate it out, and then this is the area where the vitreous fibrils are seen, and then I'm going to put in the OVD. Once the globe is formed a little bit, I'm going to make two side ports. The right side port is away from the main phaco incision, and the left side port is beside the scleral tunnel incision. So the first thing to do is obviously to do the vitrectomy. I begin by keeping the bottle height a little bit low. The cutter is introduced into the eye with its bevel facing down, and I begin the antivitrectomy. So as the vitrectomy is being done, one can notice that the morphology of the posterior capsular tear does give us certain clues. I can see that the apical region of the posterior capsular tear is slightly kinked, suggesting possibility of a vitreous fibril there. And also the iris near the clear corneal incision in that quadrant appears to be slightly peaked. So again suggesting the possibility of a vitreous strand there. So I'm trying to reach that area with the cutter through the same port, but I'm not able to get an access. So I come through the main incision and then deal with that particular strand. Now the pupil has come down in size, so I'm just putting in a little bit of a phenocaine, that is intracameral mydriatic agent, to dilate the pupil. I want to visualize the rhexis margin. So it does dilate a little bit better now, but still I'm unable to visualize the edge. It takes a couple of minutes to complete the vitrectomy. And finally, the strands which are near the apical region identified in high magnification and are dealt with. So now it seems that the vitrectomy is adequate. It's important to do adequate vitrectomy simply because if the vitreous is still hovering near the posterior capsule, the moment we try to place the lens inside, the vitreous again starts to collapse out. So it's better to do a little bit more vitrectomy than what we think it's enough. I'm just confirming the absence of vitreous all around, and now is the time to go in and place the intraocular lens. So I'm going to use the Y hooks to retract the pupil just to visualize the extent of the rhexis margin, and I think there is enough support. I am unable to see the edge of the rhexis margin in 1/3 of the circumference of the entire area. So I feel that the sulcus placement of the lens is reasonably safe, and I'm going to use cohesive OVD to create some space between the iris and the capsule. Mind you, the moment we inject OVD, everything goes into the vitreous cavity because the posterior capsule is open. But still, this OVD is slightly better and it retains the space for a good enough time for us to navigate the lens into the sulcus. I'm using the second instrument to retract the iris so that I can see where my distal haptic is going in, and the first haptic goes in and the second haptic again I'm dialing in. I'm ensuring that I'm able to see the impressions of the haptic under the iris. I'm just trying to lift it up so that I want to be dead sure that the haptic is just below the iris and not inside the vitreous cavity. During this process, there is some amount of bleed which is happening and it has gone into the vitreous cavity. Again, I need to deal with it. So I had to remove the OVD as well. So again, I go in through the side port incision, lift the lens up with the cutter and do the cleaning job. The blood clot, the OVD and some of the remaining vitreous is then cut and aspirated out. The visual axis seems to be very clear. I'm tapping on the lens to just ensure that the lens is very stable. Do I need to do an iridectomy in this case? Well, I'm not doing one in this case simply because I'm certain that there is no vitreous hovering around which can increase the risk of a pupillary block, and neither there is much of a lens matter inside. So if there is any risk factor of inflammation or pupillary block, the risk of a secondary glaucoma is a possibility. I don't see any of that. So I'm not doing any antivitrectomy. Time to close. So I'm going to use 2 10 nylon sutures to close the sclerocorneal incision. The knots are then buried inside. The remaining ports are hydrated. The conjunctiva is closed. Intracameral antibiotics are placed, and that's it. The case is done. Now, these are the next day post-op pictures, and the patient is seeing pretty well. So the moral of the story, if you have a difficult situation intraoperatively, it's perfectly fine to just get the nucleus out and maybe plan a secondary lens later on. So if the surgeon is overwhelmed during the primary surgery and the decision making can become a little bit difficult, but in such situations, it's okay to wait for maybe a couple of weeks when things become a little bit calm and you can think better. Maybe there's a time one can plan a secondary implant, especially for the beginner surgeons who with lesser experience who may be getting too overwhelmed when things go wrong intraoperatively. Well, it would be perfectly fine just to postpone the lens implant at a later stage. So that was it. Thank you for watching and hope you found this helpful.